going to move on to Article 3 now. This is Dr. Jupiter's article, Olecranon Osteotomy for Exposure of Fractures and Non-Unions of the Distal Humerus.
Okay, so I'm here with Dr. Jupiter. We're going to talk about the paper on Olecranon Osteotomy for Exposure of Fractures and Non-Unions of the Distal Humerus. Dr. Jupiter, thanks for joining us. I think my first question I'd be curious to know is kind of what was going on at the time that you decided to come out with this paper. I've done a little bit of research on it. It's obviously prior to this there's a lot of literature published on problems with doing an olecranon osteotomy and non-union after it. But what was kind of going on at the time that led you to do this study?
Yeah, that's you surmised that very well. The experience in the literature was somewhat negative regarding this technique. Because you are creating a fracture, it turns out that the actual fixation of the osteotomy was proving to have some problems for a number of people. This is a technique paper. In the era of randomized controlled trials, etc., we've lost sight sometimes of analyzing a technique, and if it's done thoroughly, it can provide information for the reader, for people. So I learned during my residency in the late 70s, this was about the only approach short of procedures for total elbow arthroplasty. And it became evident that there were specific pitfalls and pearls that made the osteotomy more predictable. And I can go through that with you if you'd like.
Yeah, I think that would be
great. Yeah. In the first place, it is good to know where the ulnar nerve is when operating around the proximal ulna or the humerus. There's a lot of variation in how people deal with it in fractures, and the Canadian Combined Study Group looked at the ulnar nerve specifically and found more than a handful of people had ulnar nerve symptoms after surgery, regardless of what you did with the nerve. But most resolved over time, but it takes a long time. But I've always felt that not only knowing where the nerve is, but I like to mobilize it sufficiently as it goes into the two heads of the flexor carpi ulnaris and proximally up to the medial intermuscular septum. And this is where you see problems with the nerve when it doesn't do well. It either gets adherent in one of those two places. So I think it's worthwhile in most cases to do this, especially if patient has preoperatively symptoms. Okay. So this next thing is where to and how to do the osteotomy. You would like to do the osteotomy in the very center of the hyaline cartilage. And actually, many studies have looked at the anatomy of the olecranon sulcus. And believe it or not, there's robust cartilage on the coronoid, and there's robust cartilage in the olecranon tip, the very proximal olecranon, but not in the middle. In fact, many patients will have no cartilage there at all. So that's a good place to make the osteotomy. But how do you define that very well? Well, one way is to lift up a little bit of the anconeus off of the lateral side and take a look inside. And you'll be able to get a much better appreciation of that area of the center of the olecranon sulcus. So we'd like to do that in a way that we can be more confident that the majority of the osteotomy is done in that spot. So the next thing is, if you can put a sponge or tape or something from the lateral side to the medial side, that will help you to elevate up the olecranon. And when you're doing the osteotomy, avoid injuring the cartilage on the end of the humerus. That'll be your protection. I've always felt that creating the osteotomy in a, what people call a chevron manner, has several advantages. They are that you can reposition the osteotomy, and it has some inherent stability because it's not a transverse osteotomy with very little interdigitation of subchondral bone. And secondly, it gives you a broader interface that for healing. So that always made sense. And if you get an idea of creating the osteotomy with the distal tip of that chevron somewhere near the center of the olecranon sulcus, it will be very safe. And then traditionally, we were taught to use a very thin blade and cut in a power saw 2/3 of the way across, and then complete the osteotomy with a thin osteotome. And the rationale for that was that there would be some irregularity of the surface of the anterior surface that might help also for interdigitation. Okay, so we've done that, and then elevate from distal to proximally as much as is needed for exposure. And the exposure, frankly, is the best exposure for more complex articular fractures that are distal to the olecranon sulcus. Those are very more difficult to gain visualization. When doing the osteotomy and elevating this olecranon up for non-unions, especially supracondylar non-unions, those patients have been moving through their non-union and not necessarily their joint. And so when you elevate it up, you have to be careful that you're not pulling off cartilage from the distal humerus. So that's the approach, okay? Then the problem is how to give you stable fixation. And that's really the method of treating olecranon fractures at the same level. The K-wires, if you aiming them slightly ulnarward and from the dorsal or inferior surface of the proximal ulna, and try to get into the anterior cortex of the ulna, distal to the osteotomy. And you better to place 2. It gives you simply rotational control.
Yeah.
And if you can do that, you want to control that with X-ray to make sure you're not headed toward the radial side, because there have been reported cases of people having problems with their forearm rotation because the tips of the K-wires are hitting the radius in rotation. And then you can bring back we brought back the olecranon into its original position, and by making a drill hole, maybe 2 centimeters distal to the olecranon osteotomy, and you take a pointed reduction clamp, that will help you in the stability of the reduction while you're placing the K-wires and then placing the tension band. The secret of the tension band is you have to have an adequate length of coverage to control the forces that want to pull it apart. And so if you look at measuring the tip of the proximal ulna to the olecranon osteotomy, you need to be at least as distal to the osteotomy as that, and preferably more. So the main problems that people found in fixation were the K-wires would back out, the way to stop that is to bend the K-wires twice, so it has a 90 degree bend, and then hammer them into the proximal olecranon. They won't back out if that's the case. Because when they do back out, it impedes people's extension. And the second is the size of the wires. Remember, many of these are done by orthopedic surgeons who like bigger and stronger, and better is that. If you use smaller wires, but use two of them and space the distance even further from the osteotomy with the second wire, it really presents very little problems with people leaning on these tension wires. So that's how I came up with that. And as a result, when people were sort of starting to say, well, we've got these anatomic plates and we've got, or these cancellous screws and all this and that, and I don't want to get into trouble with doing a fixation and having to take it out. Or people started to avoid osteotomy with different tricep splits or elevation on either side, but sometimes that's not so good with the complex articular fractures. I thought it would be worthwhile to look up my own personal experience, consecutive experience, and then report that. And so we don't see that many papers anymore by technique. And I remember a surgeon out in your way in California, Los Angeles, Joel Mata.
Yeah.
And Joel presented a series of 100 and something pelvic fractures done through his own extended anterior lateral approach. Yeah. And the results were rather spectacular. And he said, this is not and it was in Journal of Orthopedic Trauma a number of years ago, this is not a randomized prospective study. And it's a way to show if the technique is done, he sort of said correctly, yeah, but avoiding the pitfalls, and by an experienced person, this is what you would hope the procedure would do. And so that's the genesis of this this paper.
That's great. I feel like that's a great discussion. You covered everything, I think, through the whole paper, and pretty much all the questions I had.
Well, there's another paper that was probably 3 or 4 years ago from Edinburgh, the group there, and they looked at their experience with olecranon fractures, comparing plates or osteotomies as well, plates versus a tension band. Yeah. And more secondary surgery was needed for tension band, but as I mentioned, it was done because pins were a problem or the tension wires were a problem, and that can be avoided. But they found when you had plates, and in some of the older age patients, they had wound breakdown. And if you have wound breakdown over an implant at that area, which is notorious for not healing so well, yeah, that presents a major problem. Okay. Yeah. So that's another thing. And the final thing is, if you have comminution, of course, that presents a different story. You don't want to have that with an osteotomy per se. But if you have a fracture and you have going to do a tension band, an olecranon fracture, but the opposite cortex, meaning the articular side, is impacted or not intact, you have to be careful with a tension band because it will flex. In order for a tension band to work, by definition, the opposite cortex has to be intact or created with a bone graft or something else. Otherwise, you'll have a big bending moment, and that won't work.
Yeah. Are you still doing double wire for your tension band, or?
I've never changed. Oh, wow. You know, that's from mid-70s.
Oh, if it works, it works.
Because it works.
Yeah, yeah.